So what I'm going to do this time and attempt to do over time is essentially go through more or less a simulated assessment process followed by the decision-making process as to where I would take the patient based on what I find. Now I'm going to let you know that the findings will be simulated for the purpose of exposition or for the purpose of description so that you understand this better instead of this is what I'm finding on this particular individual, because clearly I seem to use the same individual in every video, and for him to be that different each video would be somewhat difficult. But essentially what I will do is go through a very, very generalized assessment using the concepts of assessment, so macro identifies micro, preferably patient active before patient passive, and being organized, right? Also, if you look back at my assessment videos or very early on, one of the things I talk about is purposefully testing all planes and all things in a rigorous way until you figure out what gives you the greatest yield, so you can remove redundancy, right? So what I'm going to do is something that I would very generally do with most patients. I want you to bend to your left, like a little teapot. Good. Bend to the right. Good. Okay, so there I notice some difference. You don't necessarily see it as clearly, so there's some difference where when he bends to his left, he collapses fairly well throughout the full vertebral column, doesn't collapse as well to the right. So I'm interested in what's happening between those two sides. Okay, so that's essentially my vertebral assessment. Obviously, I can get more granular, but I'm not going to. Will you lay on your back? Okay. So once I notice a large asymmetry in a very simple test like that, I don't necessarily need to dig deeper because I've already identified where I believe there may be some dysfunction. Okay, so side bends left, okay, not as well to the right. All right, so I just check through the lower limbs to see if I notice something. Right, immediately I'm interested in the left leg, not as interested in the right leg so far. So I'm interested in the left hip. I'm also interested in the left side of the lumbar region so far. Right, I check through the arms. Now often I would do that at the same time, however, I am going to do this independently because if I can't remember what the right arm did versus the left arm, my memory may be questionable. Often I would test the neck, but based on the position of the camera, I'm not going to do that. So I would test the neck prior to what I'm about to do, but I'm already interested in the left side of the lumbar column and the left hip. So what I'm going to do is purposefully choose to put my patient on their stomach so I can expose the majority of the left hip and I can expose the lumbar region, obviously bilaterally, but I'm more so interested in the left, so I will have you flip to your front. Right. So I'm coming over here just for the purpose of talking, but what I'm interested in, as I said, so when he bends to the left, he bends fairly well in a comparative sense when compared to bending to the right. So when you cannot bend as well to the right, that would suggest that the muscles on the left side are not letting go as easily. So they may feel firm, they may feel soft, but ideally they'd feel different than the right side. As far as the left hip is concerned, and you can see a video where I talk about how I approach the hip, essentially what I would do here is I would be interested in identifying the trochanter and then identifying soft tissues between the trochanter and the pelvis and assessing them. So the way that I would assess them is primarily go perpendicular soft tissue direction. So I come in generally broad contact, I identify the trochanter, and I'm going to go above and below the tissues that span from the trochanter to the pelvis, and they're somewhat on an oblique angle. So because as I push into the soft tissues, I'm looking for soft tissue yield, so I would still consider it a motion test. I check here, I check here. In a comparative sense, I'm more interested in the tissues that are above the hip, so I can just go right in to a simple treatment as far as being interested in that soft tissue yield, working perpendicular soft tissue direction, as you would find more often than not in older osteopathic texts. Right, so this is more or less what it looks like. It looks very, very simple, looks exceedingly basic, right? I've chosen to go short lever alone. I can go mixed leverage, and to do so, I would end up grabbing the patient's shin to use the femur as the lever. In this case, I will show it to you in just a moment. So what I'm more or less doing right now is myofascial release. To go into that longer lever, I'm going to have to change what I'm doing. So because I want my hand to be going down on this angle to go perpendicular to soft tissue direction, I can't just lean in. I'm going to turn my hand, go there. So now I've got short lever, long lever, foremakes leverage. Right? Just paying attention to what it does or doesn't do. My aim is the tissue itself, more so than the joint play or the joint motion. Just going through here. So again, I have my two large curiosities. The reason that the patient is on his front would be well described by how I choose patient position. So I want the anatomy exposed, free to move in the plane or planes required, preferably visible for both of the pieces of anatomy that I'm interested in. This hits that. So as far as the lumbar column, I just come in and do soft tissue work perpendicular to fiber direction. Because what I want to try to identify in my treatment process is whether or not this is more of a soft tissue issue or more of a bony tissue issue. The way that I'll find out is to retest with the tests that I use to find these. So I will apply treatment for a short period of time so that I'm not necessarily meandering and just talking just to see if I can identify a difference. The differences in these two tests will not show up as well to the camera because of angle, and I completely accept that. So if you're saying, oh, well, it didn't look all that different, I didn't exaggerate these tests to make it look that different, but I am trying to show I can do two things. I can find things in varying points of the body, and I can put the patient in one position to do the work that I want to do. All right, so I'm just going short lever on the soft tissue. I can go mixed leverage, so I basically start to jiggle the patient's pelvis so that I hold the soft tissue still, and then I move the bones underneath it, right? I can use the leg to create the motion, right, in a rhythmic fashion, but basically I hold onto the soft tissue, I move the bones under the soft tissue. I can do it on this leg, I can make it look fancy, I can tell you all kinds of fancy things about me wanting to use the sacrum as a handle and pump the sacrum, but realistically all I'm concerned with is holding the soft tissue still and moving the bony tissue under it, so that's relational motion. Right? Here, let me flip your back. Right, so here, what I want to do is make my decision with respect to how I move the patient to check the hip first and then the back, because the hip is the easier thing to check from that supine position, or sorry, from that prone position. So if I go from prone to supine, easier on the patient. If I go from prone to seated to supine, it may disturb the patient a little bit more. Now I don't need to run every test on the left leg. I need to run the test that is of curiosity or of concern, and that's essentially just adduction, right? So I check the right leg because I know it was the good one, I check the left leg against it, and there's some change, right? So that's how I figure out if it did what I wanted it to do. It did some of what I wanted it to do, it didn't do everything. I can then go choose a method where from here I would maybe go into something like leg rotation, internal external rotation of the hip, some form of extra hip treatment. I'm not going to do that right now for the sake of brevity. Sit on up. So I use the test that I found it with. Okay, so I want you to bend to the left because we know it was the good way, bend to the right, and some change, right? So again, I know that you're not necessarily going to see it, but the point is to show you how I'm processing, how I'm going through those things. So I found two things, left low back, left hip. I put the patient in a position where I could address both of them without flipping the patient around too much. To retest, I go back to the test I found it with, so I flip the patient into supine to check the hip, I put the patient into seated to check the low back. I have found change in both. So the point of this is to show you how these concepts play in a simulated situation such that you understand the decision-making process and how we go through it. We'll exaggerate more things at another time to make it a little bit more notable to the camera and the camera angle, because I only have one camera and that's how I run this. But that's the point. The point is to talk to you about things like patient positioning. You know, anatomy should be exposed, free to move in the plane or planes required, preferably visible. We hit that with the prone position for the low back and the left hip, right? We want to be organized in our assessment approach, so we recheck with the test we found the thing with. We want to go patient active, preferably before patient passive. We want macro identifies micro, and that's what we have shown here.